Hello and welcome to today's webinar, Centering Pregnancy, a Group Healthcare Model for Prenatal Care, sponsored by Elsevier's Clinics Review Articles and Physician Assistant Clinics. Please note, your line will be muted and the presentation will be recorded. You may submit questions at any time using the Q&A feature located on the right. Today's presenter is Heather P. Adams. Heather Adams is an associate professor in the Physician Assistant Department at Gannon University and clinically practicing PA at Women's Wellness and Gynecology, both in Erie, Pennsylvania. Heather is a member of AAPA, PSPA, PAEA, ACOG, and APOG, also serving at the Publications Committee Chair for the last 3 years for APOG. Heather has over 10 years of experience in women's health care, including gynecologic and obstetric care. She has numerous women's health-related scholarly achievements, including state and national professional presentations, webinars, and peer-reviewed publications. A recent publication includes one on centering pregnancy, the topic that she will speak about in this webinar. Thank you for being with us today, Ms. Adams. Please go ahead.
Good afternoon, everyone. I'm excited to present on this topic of centering pregnancy. Just to give you a little bit of my background, I was first introduced to centering pregnancy by my supervising physician, who is in the process and has been for several months in applying for and launching a centering pregnancy program in our area, which would be the first centering type program in the Erie area. So while I've not seen patients under this model, I understand a lot about it because of her education and the publication that we did together. And I value this type of model, and I think it's worth promoting at this point. So that's one of the reasons why I'd like to present this information to you today. So as far as learning objectives go, some of the things that I hope that you will take away from this presentation is to better define and understand the group healthcare model known as centering, more specifically centering pregnancy, be able to paraphrase the history of the development of centering pregnancy, to describe the details of the centering pregnancy model and be knowledgeable about details of what that program would look like for patients or for facilitators, to recognize the benefits of centering pregnancy group prenatal care, recognizing the challenges and limitations, because when there's benefits, there's always challenges and limitations to address as well, and to be able to identify and locate the different resources available, including where there are centering type programs that providers could refer their own patients to. First, let's take a look at centering in general and what this concept is. Centering is a model for healthcare that offers an alternative to the traditional face-to-face exchanges that happen between patient and provider, where you're in a private room and it's a single patient with a relatively brief period of time that they have to spend with their provider. Then the provider moves on and kind of works through their day that way. So the goal of centering is to bring patients out of the exam room and into a group setting for care. There's 3 main components of the all centering models, with centering pregnancy being one of the models underneath this umbrella. And the three components include the health assessment piece, the interactive learning piece, which is the group-based model, and then community building. And community building is something that's very unique to this type of healthcare model. And based on that group facilitation of discussion and activities and whatnot, it really helps to build camaraderie amongst the participants. We're going to look at these 3 components of centering in a little bit more detail. So with the health assessment, you have both the provider and the patient are involved just like they would be with traditional health care, and they're really playing an equal part. They're both involved and invested in this type of program, this type of model for healthcare delivery. There is an allotment for one-on-one time with the provider, so that's one really important detail when educating people about centering programs in general, is that patients will absolutely have that one-on-one time with their provider where they can discuss very private issues or bring up concerns that they might not be comfortable bringing up in the group setting. In addition, with this type of health assessment, the patients are empowered to be involved in their own health care. So with this model, gone are the days of providers scripting to patients exactly what they're to do and then patients following those instructions to a T. So what we want is more of a collaboration, and this model really gets at that. The interactive learning piece, so this is where the group the group learning really comes to the forefront. So the discussion and the targeted activities that happen in group are facilitated by a trained facilitator, and these are really dictated by the commonality amongst the group. So the facilitators are trained to kind of identify those different topics and things that they can talk about at a given time in order to make the most out of that type of education. Patients are going to become very informed. They'll be highly educated through this type of healthcare model. And what we are starting to recognize is the more informed they are, the better types of outcomes we start to see. Patients start to panic less when things go wrong because they have some background knowledge and some information that's been provided to them in this educational capacity. And they grow in confidence. They increase their self-esteem. They feel more empowered to make some of their own healthcare decisions. The community building piece, this is also really focusing on the group setting with participants that have commonality amongst them, and so they've got some things that they can talk about. They might be from completely different walks of life, but this program is going to bring them together in a way that focuses on their healthcare needs. A lot of times the question and answer, the facilitation of the group process is really driven by the patients and their questions, and what is recognized is that as patients develop these questions that might spark other questions in individuals, certainly there's going to be a lot of education that takes place with someone else's question that a given individual might have never thought to ask. So there's just a lot of room for increased knowledge base when it comes to the patients and their health care. There's a decrease in the stress and the isolation, so they're not sitting in a stark white room with a potentially intimidating healthcare provider. They're in a group of their peers with a facilitator. They're circled up so that everybody's playing an equal role as opposed to orienting them in rows. So it becomes a really low-stress, low-key environment where they can learn a lot and they can begin to apply all that information to their own health care. And we talked before about how there's this camaraderie, these friendships, and these support systems that develop that might last well beyond the group, the group coming to a close. So potentially lifelong friendships and other people to reach out to for support. Some of the benefits of centering in general that have been proposed are just better care, and this is argued based on the fact that the participants tend to be highly educated and aware of their bodies. They're changing symptomatology based on their disease processes, and so care becomes better. They're more aware of what's going on, when they need to be seen, when things can be managed on their own, and they just have a good background of knowledge. All of these programs continue to follow nationally recognized guidelines, so there's nothing that's really being left out as far as the care that's provided. The guidelines are all followed. It's more this addition of this intense group setting where so much education and camaraderie can be built. there is some evidence that we will look in more detail that there are better health outcomes that come out of centering pregnancy. And the real takeaway is that there are numerous studies specific to centering pregnancy that show some better health outcomes. In addition, there's this really clear evidence that there's no worsening of health outcomes. So at the very least, this can just become another option for patients who like this type of model of care. There's also some theories that this could lower healthcare costs, improving health outcomes, decreasing emergency room visits and unnecessary health care visits or calls to providers because the patients are just more educated about their condition. So now that we've generally talked about centering, we're going to move into centering pregnancy and what this specific type of centering involves. So centering pregnancy is really a model for group prenatal care. It's designed to empower patients to have a role in their own pregnancy and prenatal care. It increases the amount of time the patient has with the provider, still getting that one-on-one time, but then having a vast amount of time that they'll continue to spend with that provider as that individual facilitates the group sessions. It provides targeted patient education through discussion. And with prenatal care, you can get really specific about at what point in a pregnancy do we want to talk about things like identifying a pediatrician or educating on breastfeeding or discussing labor and delivery and what that might look like. And so the conversations in the group activities are very targeted based on the gestational age of the patients within the group. And it provides this really nice, safe environment for women to start their motherhood journey. Some of these women will be moms for the first time. Others will be in subsequent pregnancies, and they can serve as mentors. It's great networking. They can share tips of the trade. They can talk about childcare and all sorts of things that moms to be might have questions about or might not even realize that they should be researching these types of topics. So it's just another network of support for these women. So as far as the history of centering pregnancy, this was first described by a nurse midwife by the name of Sharon Rising in the 1990s. So it's a concept that's well established. At this point, it's been around for quite some time. Initially, when Sharon Rising was describing this model, she talked about three components. The risk assessment component, that's very important for all prenatal care, and there's really some standards that have to be met when it comes to risk assessment of patients. Those standards are still met with centering pregnancy. Also, the education piece. In women's health and in obstetrics, we do a lot of patient education, and so this provides an opportunity to do even more of that, and in different ways, as opposed to just a provider talking to you for 5 or 10 minutes every visit about a new topic. Now we have an opportunity to spend much more time in a group setting with activities and guest speakers and different things to keep it interesting. And also there's that level of support that we've talked quite a great deal about. So one quote from Sharon Rising is that women are encouraged to take responsibility for themselves. This leads to a shift in the client-provider power base. So shifting some of that power of healthcare away from the provider and into the hands of the patient to really empower them to want to be their best individual. So what Sharon Rising did is she developed a pilot program, and she had 3 hypotheses that she was looking to prove through this pilot program. And these included to have pregnancy outcomes at least comparable to the general population, to show decreased use of the emergency room during the 3rd trimester, and I would add that that's really where that education piece comes in, like what do I need to get excited about, what don't I need to get excited about, to show evidence of learning or improvement in education and knowledge base, and to indicate satisfaction with the group approach to prenatal care. So how satisfied were they with this, with the prenatal care that they received? Here's a little bit more detail on the pilot study. So you can see some of the demographics here. We had people, women under the age of 20 and those in their 30s or older. First pregnancy, second pregnancy, third pregnancy, so both nulliparous patients and in folks who had multiple children at home and maybe were a little bit more experienced. And then several patients, 3/4 of the patients initiated their care early in the first trimester, or at least in the first trimester, which is the recommendation. And just 4% started their care more than halfway through their pregnancy at 20 weeks gestation. So here are the results of this initial pilot study. So what she specifically looked at was the rate of cesarean delivery, or C-section rate, the APGAR scores, which would directly translate to a pregnancy outcome, fetal health at the time of delivery, and then visits to the emergency department in the third trimester. And recognized that there were good pregnancy outcomes associated with this centering pregnancy model, and she was able to identify that there was no worsening of these pregnancy outcomes with the group prenatal care model. When it came to the final evaluation form, you can see those percentages at the bottom of this slide, indicating that patients were highly satisfied with the level of prenatal care that they received. So here are her hypotheses again and the different conclusions that came out of this pilot study. So as far as pregnancy outcomes that are at least comparable to the general population, this was supported. It's unclear to me if there was statistical significance indicating that centering pregnancy had better health outcomes, but it was quite clear that they did not have worse health outcomes. And that has been seen throughout the number of studies that have been done in the last 30 years, that premise is really well supported. She wanted to show a decreased use of emergency room visits during the third trimester, and that was also supported by the quantitative data, and it was statistically significant. So we're showing better education for our patients is decreasing the stress of them having to go to the emergency room. We're saving healthcare dollars for patients, for insurance companies, and that really benefits everyone. Her third hypothesis was to show evidence of learning, which was also supported in her quantitative data and the qualitative data, and then an indication that there was satisfaction with that group model was very well supported with the qualitative data. So let's take a little bit of a closer look at the model itself and what this includes. So we talked generally about centering models, but now let's talk more specifically about centering pregnancy. So what would happen in a facility that offered centering pregnancy is they would perform a traditional pregnancy intake on a patient. So the patient calls with some indication that they're pregnant, and they come in and have that initial one-on-one intake, and at that point in time, they would get education about the two options of prenatal care. So traditional model that we're familiar with or are the scheduled out visits every month and then every 2 weeks and finally every week in the end of the third trimester, where they would see a provider one-on-one, get their education and their health assessment done that way. And then education would be provided to that individual about the centering pregnancy or the group healthcare model. They could kind of self-select. There might be some folks who wouldn't be the best candidates for the centering pregnancy model. So ideally, we're looking for lower risk patients. Someone who's extremely high risk with their pregnancy might be going to see specialists, and they really need that individualized time. At that point, they're probably coming in for more prenatal visits than the standard. And the group model is really based on visits every month up until well into the second trimester, then every 2 weeks and every 1 week at the end of the third trimester. To form groups, they're going to look for 8 to 12 interested individuals, low-risk patients, plus a support person, so a spouse, a partner, a family member, a friend that they can bring with them to their visits. You want to create groups of women who have similar estimated due dates so that topics of discussion are most relevant to all individuals in the group. The first time the group would meet is going to be between 12 and 16 weeks. So they'd have their initial intake roughly around 8 weeks of gestation, and then between 12 and 16 weeks they would have their first group meeting. The model consists of 10 different group sessions that can last from 90 to 120 minutes, depending on how long it takes to get through those one-on-one assessments, how large the group is, what the activities are, what the topic is, and that sort of thing. And that will transpire over the next 6 months to the end of pregnancy for those women, wrapping up with a postpartum session where everybody would come and have their postpartum needs met with a postpartum visit and one final group session. So here's a quote: because the Centering Pregnancy program includes the same physical assessment and education as the traditional prenatal care, it meets the standards set forth by ACOG and AAP. So ACOG is the American Congress of Obstetrics and Gynecology, and AAP is the American Academy of Pediatrics. And so just to highlight that we're following all the guidelines, all of those standards are being met, and we're adding in some of these other additional benefits. A table that's going to describe what this appointment structure looks like once we get into the group model. So the first 20 to 45 minutes is when that provider would spend some individualized care with each individual patient. The patients are encouraged to come in to the facility, get their own weights and record their blood pressures, do a urinalysis for glucose and protein. So some of the things that are traditionally done by medical assistants or LPNs or nurses in the traditional setting, the patients are actually doing that for themselves. And this adds another level of confidence and empowerment for each individual. And then they'll take turns having that one-on-one visit with the provider where they're doing things like measuring fundal height, listening for fetal heart tones, doing other physical exams as indicated. It could be vaginal cultures, it could be abdominal exam, it could be listening to their lungs, whatever that provider feels that individual needs. So that part of the visit is very much like the one-on-one visits that are associated with the traditional care model. While those one-on-one visits are taking place, the rest of the group is interacting and bonding. They're doing maybe some homework that's leading up to the discussion for that day and the educational piece that is targeted for that visit. Once those one-on-one assessments are done, they'd move into the group session where they'd all circle up, and that's at that point, the facilitator would begin the educational piece. Sometimes that'll include bringing in a guest speaker, sometimes various activities, whole group activities, partner activities, and then the education kind of develops from there. The provider really acts as a facilitator and not a dictator role in this part. So the discussion is very much driven by patients and their concerns, their questions, and what other needs they might have. So it's possible the facilitators need to be very adept at kind of reading the needs of the group, not allowing anyone to dominate, making sure everyone has a chance to participate, keeping them on task, and that sort of thing. So it really becomes a true facilitator's role. Questions are encouraged, lots of opportunity to learn from other individuals' questions, and then oftentimes some literature is going to be provided, whether it's just a brochure, a pamphlet, a chapter in a book, whatever that might be, something that they can take with them and refer back to when it comes to that educational piece for that day. Here is a table of suggested educational topics based on the gestational age of the individuals in the group. So just some suggestions, and these can all be developed by the facilitator. The facilitator of the group would be very capable of developing their own model and doing what works for them. But, you know, at 16 weeks, maybe you bring in a nutritionist. At 20 weeks, a physical therapist to talk about some of the different challenges, musculoskeletal challenges of pregnancy. At 24 weeks, maybe discussing the benefits of pregnancy yoga, and then adding in a session of yoga for the individuals. At 28 weeks, a family psychologist talking about family dynamics, how intimate relationships change, relationships with other children, if there's any coping issues or behavioral type of issues with other kids, how do pregnant moms deal with that. At 30 weeks, bring in a lactation consultant, talk about the benefits of breastfeeding, other options, what to expect kind of when that opportunity arises for breastfeeding. 32 weeks, bring in a labor and delivery nurse, have them share some stories, give them some ideas for birth plans. Maybe the activity at that point would be developing their own birth plan or starting that process. At 36 weeks, bring in a women's health care provider, maybe one of the delivering providers in the office, and talk about contraception. What are the options for contraception that they will have immediately following delivery and more long-term? What are their contraception goals? Are they wanting something long-term? Are they wanting something permanent? Are they, not desiring anything after delivery? 38 weeks, you can bring in a nurse educator, talk about postpartum depression and the risk for that, what to do if you feel like they're starting to get the baby blues. Then at 40 weeks, a social worker maybe to talk at this point about infant care because they're just about ready to bring home that infant at this point. Parenting strategies, what resources are available in their specific environment, in their location. And then at a postpartum visit, there would be lots of other opportunities and ideas for discussion and for activities at that time. So we're going to talk a little bit about some studies that have been done that I want to just kind of get into the science and the data, the statistics a little bit so everybody is very comfortable understanding the potential benefits of this program and making some recommendations based on that. So there was a study that was conducted that showed these three different components to what women desire in prenatal care. They identified that women desire continuity. They like the idea of seeing one provider. They desire comprehensiveness, so they want to have thorough health assessments, but also thorough education. They want to talk through their concerns, have opportunities to ask questions and discuss different topics that are relevant to them. And they also desire some element of control. They want to be able to have some empowerment and be able to take some control over their own health care, over their prenatal care specifically, identifying their own needs and discussing those topics when they arise. So here are some of the proposed benefits of the Centering Pregnancy Program. These are really seen from the Centering Healthcare Institute website, as well as found in a number of different articles that have been written about centering pregnancy over the last 30 or so years. So some of the proposed benefits are community building, increase in those support networks, development of problem-solving skills, so being able to identify what's a concern, what's not a concern, improving self-esteem and self-care, making these women feel better about themselves, increase in knowledge base with the educational components to the program, increase in healthy behaviors, educating on smoking cessation, healthy eating habits, when is it okay to exercise in pregnancy, what should be avoided, those types of things. Improving patients' quality of life. Increasing the amount of time spent with the provider. Increasing the patient satisfaction with their health care, their prenatal care. Finding a cost-effective model, use of resources and facilities, and developing those ongoing relationships amongst the group members that can continue on for a long time. So you can see a pattern here that a lot of these proposed benefits really relate back to patient self-esteem, empowerment, support, camaraderie, the relationships that they have built that are really only available to them through this group type of model. there's several studies that have shown evidence that there is improvement in various health outcomes. So some of the improvements that have been identified through studies include some very tangible health benefits, things like lower rates of preterm delivery, lower rates of low birth weight, increasing in breastfeeding rates with an increase in all of the benefits that go along with that, improve patient satisfaction, increase in family planning, so thinking about after delivery, what's the family going to look like, what's our goals for subsequent pregnancies, what's the contraception options that are best for individuals, increase in prevention of unhealthy behaviors or things that put patients at risk for sexually transmitted infections or diseases, and then improvement in preparedness for labor and delivery. So some women who have inadequate prenatal care, meaning that they maybe aren't going to all of their visits, they don't understand the recommendations and the standards, they can go into labor and delivery very unprepared, not knowing what to expect, not knowing what their coping strategies are, and that makes it difficult for all those involved. And one point that I really want to drive home is that, while studies vary a little bit in what they've identified as some of these improvement in health outcomes, all studies are showing that there's no evidence of harm by initiating a centering pregnancy model for prenatal care. So at the very least, this becomes a great alternative to traditional prenatal care models for patients who feel like this is a good method for them to receive their health care. We're going to go through, on these next 3 slides, some specific studies that I think really identify and tease out some of these potential health improvements that we can see with this model. So you can see that this study was performed in 2004 by Grady and Bloom. It was a retrospective chart review, and they measured a number of different outcomes. So the level of significance in these 3 charts is determined to be less than 0.05. So a p-value of less than 0.05 shows statistical significance. So in this study, we see statistical significance with improvement in preterm delivery and low birth weight when it came to centering pregnancy models of prenatal care. We also see reduction in these other elements, reduced C-section rate, improvement in breastfeeding, or an increased number of patients who self-reported that they breastfed, and then increase in the number of patients who self-identified as finding a pediatrician prior to discharge from the hospital. So not all of those numbers were statistically significant, but we still definitely see a trend that there's no harm in any of these outcomes when we come to looking at the data from this study. The next study was performed by Ikovics et al. In 2007, so a few years later. This was a randomized controlled trial, so a little bit different methodology was used for this study, and they were specifically looking at a population. They wanted to focus in on a higher risk population of African American women. And that's, something else that has kind of come to light is that this might be a really great model for some of our higher risk patient populations. So thinking about adolescents, African American women, military women or wives, populations that tend to have slightly worse pregnancy outcomes, might have more benefit, might show more of a statistically significant benefit from this model of prenatal care. So in this study, we see that all of the rates, with the exception of improvement in low birth weight, did improve with the centering pregnancy model. Interestingly enough, the low birth weight was actually flipped in this instance, and there was a slightly higher percentage associated with the centering pregnancy model. However, it was not statistically significant. So we can't rule that out as just a phenomenon by chance alone. We see a lot of improvement in some of these other outcomes that were measured. So there's statistical significance for preterm deliveries, both total preterm deliveries and those of African American women, improvement of breastfeeding rates, improvement in knowledge scores and readiness scores as far as readiness for labor and delivery and readiness for infant care, and a very significant improvement in patient satisfaction with the group prenatal care model. This third and last study that was conducted by Kennedy et al. In 2011 was another randomized controlled trial, and this one looked at women in military settings, another higher risk population when it comes to worse pregnancy outcomes. So here, there is statistical significance for some of our parameters and outcomes as well. So attendance showed a statistically significant improvement with centering pregnancy, as did epidural use, meaning there was lower rates of epidural use for those who attended a centering pregnancy model. The low birth weight is also not supported in this study as being a benefit, but you can see that they were exactly equal with a p-value of 1, and so again supporting this concept that we're not doing any detriment by enrolling patients in this type of prenatal care model. So in addition to the benefits, which we've spent quite a lot of time talking about, it's important to identify challenges and limitations, because it's naive to believe that there are none when it comes to something that's a little bit different and strays from the norm. But also, we want to know what the challenges and limitations are so we can address them and we can improve the process. So we're going to look at challenges and limitations of from a couple different angles. First, let's think about provider, staff, and administrative challenges and concerns, and then we'll look at patient challenges and concerns. So we recognize that one of the biggest concerns or hurdles that comes with implementation of a centering pregnancy program is buy-in. So if you have a practice that has all sorts of employees, we have providers of various levels, we have other healthcare workers, we have staff, we have administration, clerical workers. Really everybody needs to be on the same page when it comes to implementation of this program. The reason is everybody has a role in the education piece, or in addition, a role in the identification and recruitment piece. So you think of the folks who are answering the phones, who are scheduling patients for those intakes, the nurses who are doing the intakes, the MAs who are rooming the patients. They all have direct patient contact and opportunity to educate on the centering pregnancy model that's offered at that facility. So if they don't have buy-in, then they're potentially missing really great candidates for this type of healthcare model. So buy-in is really important, and that really speaks to the need to educate thoroughly every person that works in a facility that would like to incorporate this type of model into their prenatal care. So there's got to be a lot of opportunity for those folks to ask questions, things that they might have concerns about, like, where are we going to put this group? We need some type of space allocation for them. What if we use that space for other things? Are we going to be limited in other types of programs that we can run through that space? How are we supposed to schedule these patients? It's a different type of scheduling system. Can we bill for them? Are we still going to get revenue? Is this a productive way to carry out prenatal care? So those educational pieces are really important in making sure everybody's on the same page, has an opportunity to ask their questions and feel comfortable with the process. Some really huge challenges can be space. So they need a large space that has a linked private area. So whether this is an area that can be curtained off or whether it's actually a room, that's important for the one-on-one visits. And then in addition, they need an area that's large enough where the entire group can circle up, where they can do some activities and move around. And so that can be a challenge in some practices. Not everybody has that. So it's identifying those spaces. Are they utilizing space in a local church or some other community facility where, that meets the needs of a group healthcare model? Allocation of resources, both human resources and non-human resources. It's important for a practice to really think about what that's going to do to their normal dynamic when maybe some people are pulled away for longer periods of time. That is one concern that does surface in a lot of practices, is if you have one or two healthcare providers who are interested in initiating this type of practice, this type of prenatal model, you have other providers who are just going to keep slugging along, seeing patients every 15 to 20 minutes. There might be some bitterness that develops. Well, this person gets to take off for an hour and a half or 2 hours at a time and do their group work, while I'm here, seeing 10 patients during that time frame. And so just a lot of education and understanding, giving everybody the opportunity to be involved in the process could help tamp down some of those negative or bitter feelings. When it comes to patient concerns, again, I can't highlight enough that it's really the educational component that is most important. So when we talk about people who are scheduling the intakes, performing the intakes, rooming the patients, all those folks have that great opportunity to educate the patients on this option of prenatal care, this group option, and so they want to be able to address some of the concerns or questions that patients might bring up. So first and foremost, kind of looking at who's qualified for this type of program based on their pregnancy risk, and that's really determined by the provider. But then, everybody needs to be able to talk about this and identify who is self-selecting into a program like this and who's self-selecting out. So if you have someone who just has issues with being in public or being in a group, then that might not be the best program for them. Some of the other concerns that come out of the programs themselves are, that the meeting space wasn't adequate, they didn't like the snacks, or there weren't snacks provided. These are some real specific examples that some of the studies had teased out. So the expectation, if someone's spending an hour and a half to up to 2 hours in this setting, they want to be comfortable. So thinking about those things, addressing those needs as spaces are identified for carrying out the group meetings. The uncomfortable dynamics with the group member is a tough one, because I think that definitely varies based on who the members are, and that's very individualized. So that's where the facilitator role is so important, coming in, being able to identify when there's any stress or strain between individuals and managing that so everybody has a real positive outlook coming out of the group experience. In addition, if there's one provider who is facilitating the group on an ongoing basis, that may or may not be the person that ends up delivering that patient's baby. And so that can be disheartening and discouraging for some folks, that they aren't guaranteed that that's their delivering provider. A lot of large practices have this same issue with traditional prenatal care. If there's 15 different delivering providers in a practice, it's anybody's guess who's on call when it's time to deliver. So just being upfront with that kind of piece of things, making sure that this patient is a good fit for the program based on that concern. The long appointment times and scheduling those can be challenging for both offices, but also for patients who have very busy lives. So they can identify pretty quickly if they think that's going to be an option for them and their schedule. And then some folks ended up having an issue with the lack of privacy, but just remembering that they do get that one-on-one time. So educating them clearly about options. If you have private issues, that's the time to discuss that with your provider. So this slide talks about some of those issues and then identifies some appropriate solutions. And a lot of this is based on education. So what kind of education can be done up front to diffuse any of these problems that might arise or to address any of these challenges? So thinking about things like if they're concerned about a lack of privacy and confidentiality, having those conversations up front. Amongst providers or other ancillary staff, if there's a lack of understanding of the model, well, then we didn't do our job to appropriately educate on that model. So what we find is there are really ways to adequately and sometimes very simply address a number of these challenges and limitations, creating a more efficient and effective program in the end. So now we're going to spend some time talking about the centering pregnancy model and implementation of such a model. So what would happen, and the best resource for this is really the Centering Healthcare Institute website. They have a link. It's the Let's Get Started link, and that's essentially where you want to start if you're interested in starting up one of these programs or determining if you're ready for startup. So the first step is really to perform a readiness assessment, and that's kind of an assessment where you're not being graded. It's best to be very honest about the different characteristics of the practice as they exist, and the Centering Healthcare Institute is going to be able to use that information to determine where you are in that process moving forward. Are there adjustments that should be made before a program's initiated? Is everything in place the way it needs to be for the startup to begin? There is a practice service manager who then calls that practice, that facilitator, that individual who's identified on the readiness assessment, and is there another one-on-one person that's going to really walk them step by step through this process. There's training opportunities for facilitators, and some of the other steps include, finding a space that is adequate, educating all the rest of the practice, and that practice service manager can walk individuals through all of those steps. So here's some of the resources that are available through the Centering Healthcare Institute website. They do have a really nice, user-friendly website. The organization mission is stated here. Our mission is to improve health by transforming care through centering groups. Quite simply and adequately stated. The resources for patients that exist on the website include some fact sheets and the ability to very easily locate a program near them. There's a more significant list of resources available for providers, and this includes the Let's Get Started link with the readiness plan. There is implementation plans up there, so models for implementation. There's information about different grants. There's a flyer that identifies areas to save money in the implementation process. There are trainings up there, different programs for training facilitators, and then site approval for quality assurance. So lots of different resources for anybody who's interested in moving forward with this type of model, or at least doing a little bit of research. This is just a screenshot that shows what the program locator looks like on the website. So essentially, if you go to that main site, which is centeringhealthcare.org, there is a locator tab that you would click on. So looking for locations, and this map comes up. Then you would hover your cursor over your state, and that state turns dark. I'm in Pennsylvania, so I hovered over Pennsylvania. And then you can see that small box up in the right-hand corner is going to tell me the number of different types of centering programs that are available throughout my state. Once you click on the state, then you get a comprehensive list of all of the sites, really with their contact information. So address, different phone numbers, faxes, emails, website links, things like that, whether they're an accredited program through the Centering Healthcare Institute or not will be identified there. So if that's something that's important to you as a provider or to patients, that will be identified. And you can see that the titles here, the location names here are in purple, and those are additional links. So if you hover over those purple names and click on them, what will come up next is the website for that facility or that institution, giving you a whole other layer of details about different types of programming and healthcare opportunities that are available in that specific location. So the location of programs tool on the website is very user-friendly. So another question, since we started the conversation talking about centering in general, I want you to be aware that there are some other centering healthcare models that are out there. So there's centering parenting, which is more of a pediatric care. taking place in a group setting, so those individuals are bringing their children with them to these visits. The centering healthcare is really looking at some very specialized care in a group setting. And what I love about this is, based on what we know about the benefits of centering pregnancy for patients' self-esteem, confidence, and empowerment, it's reasonable to think that those qualities would transfer to these other highly vulnerable and sometimes isolated populations of patients. And so these groups of patients, when you think about folks with HIV, cancer, diabetes, those can be very isolating and overwhelming diagnoses. And when you put them in an environment with other people that have that similarity, they start to open up. They start to recognize, I'm not the only one, I'm not alone, I'm going to learn a lot, I'm able to share because I'm comfortable in this setting. And so through that, they become more educated and more empowered. This is another screenshot from the website that just shows the number of centering pregnancy sites across the nation. There have been some similar programs that have been developed in other countries, including Canada, Australia, United Kingdom, and then throughout Africa. But you can see all the yellow dots there that would add up to a current 585 different centering practice sites. So that includes centering pregnancy, centering parenting, and centering healthcare facilities. Here's a list of the different resources or references that I used in preparation for this webinar. And so that is the end of my slides, but I believe we have a little bit of time left for questions if there's any questions that have been posed.
All right. Thank you, Heather Adams, for sharing your expertise with our participants. I'd like to open our question and answer session. If you would like to submit a question via the Q&A box, you may enter it now. And we do have a question that came in, and it reads, what kind of training do people need to do centering pregnancy, a group healthcare model for prenatal care?
So there are different levels of training. The initial steps for setting up this type of model really relate to going to the website and starting off with that readiness assessment. So once you start off with the readiness assessment, you'll be linked up with an individual who will walk you step by step through that process. So that should be step one. You go on the website and you click on that Let's Get Started link. There is a video there as well. It's about a 7-minute quick video that really walks you through the process and details some of those different steps that'll take place. And once you've done that part, go ahead and initiate that readiness assessment and see where you are. Maybe you're more ready than you thought you were. Maybe there's a little bit of work that needs done, but that's essentially a tool to help the provider identify where they are. As far as specific trainings for providers, there are some certifications that are offered through the Centering Healthcare Institute. There's a certification, a certified centering facilitator, and a certified centering facilitation trainer. And so there's additional trainings that can be done above and beyond just the implementation process. One thing to think about with the readiness assessment is that they're really going to focus on 4 components. They're going to ask about patient volume, provider engagement, group space, and administrative support. So those are 4 key elements that someone who's trying to implement a program would need to be able to speak about in some level of detail.
All right, thank you. We have another question, and it reads, what funding support is there for centering pregnancy, a group healthcare model for prenatal care?
So as far as funding support, there's probably opportunities for different grants that could be applied for outside of the Centering Healthcare Institute. But within the Centering Healthcare Institute, they do have a link for grant opportunities on their website. Currently, it looks like what's available is a Centering Healthcare Institute Implementation Awards. And so there's a number of different 130 awards that they're willing to offer out over the period of 2 years, specifically aimed at practices that might find themselves resource limited, maybe in communities that have a great need, a great healthcare need. And so there is an application process that can happen currently for programs that are implemented or looking to implement, where they might be able to get some funding to help defray some of those costs. And then any other grant opportunities that develop through the Centering Healthcare Institute would be posted on this link. And outside of that, it's just a matter of, if someone's savvy at kind of searching for different grants and is a good grant writer, there certainly would be other opportunities for funding through grants as well.
All right, thank you. Unfortunately, we have run out of time for questions. We would like to thank Heather Adams for presenting this exciting informational webinar activity, and we hope that you'll be able to use what you learned today in your area of practice. At this time, I'd like to thank our presenter and today's audience for participating in our webinar. Thank you for joining us, and I hope to see you at a future webinar.